Hi, everybody. I think we can get started. I am Leslie Soon. I'm an assistant professor of medicine at UCSF in the Division of General Internal Medicine at San Francisco General. I have the distinct honor of introducing our speaker, Dr. Alex Kroll today, speaking at our IHPS Grand Rounds. Dr. Alex Kroll is a distinguished fellow at the nonprofit Health Research Institute, RTI International. He began his research career actually here 3 decades ago at UCSF's Institute of Health Policy Studies and the Department of Family and Community Medicine. He has been the principal investigator of 15 studies and co-investigator of 20 National Institute of Health funded projects, as well as having led many projects funded by Arnold Ventures and the Centers for Disease Control. He has been an author of over 200 manuscripts in peer-reviewed journals and is frequently quoted in Tier 1 media outlets. He holds a bachelor's degree in sociology from Georgetown University, a master's in epidemiology from Harvard, and a PhD in epidemiology from UC Berkeley. So please give a warm IHPS welcome to Dr. Kroll. As a side note, we ask that audience members please use the Q&A function if you have any questions, and we'll address them at the end of the talk. And with that, I will hand it over to you. Take it away, Dr. Kroll.
Thank you so much, Leslie. It's great to be here, and it's nice to be back at IHPS at UCSF, where, as you pointed out, I started a long time ago, 3 decades ago. I really want to thank IHPS and UCSF specifically for inviting me to give this presentation and to be here today. It's really nice to be back at doing that. This research comes from a large team of amazing people, which I've listed here. Erica Brown, statistician, Pete Davidson and Barrett Lambden are co-investigators on this project. Vero Mahano and Terry Morris are ethnographers on this project. And Kadi Megarian is a project manager on the project. Brad Ray is a co-investigator, as is Leslie Soon. And finally, Lynn Wenger is also a project director on this project. So it's a large team of great people who have been part of this really unique project, and we're excited to share some of the findings from that work today. So just to begin, what are overdose prevention sites? Essentially, they are places where people can use pre-obtained drugs under the supervision of a healthcare professional equipped with naloxone or oxygen. These sites can go by other names as well, including safe consumption sites, supervised injection facilities, or drug consumption rooms, among other names. Legally sanctioned OPS have existed globally for over 35 years and currently operate in over 150 cities in 13 countries, including in Europe, Australia, Canada, and now recently the US. In fact, the first government sanctioned OPS was opened in the United States just over a year ago by On Point NYC in New York City, and that was the first one after so many years. The evidence base, the global evidence base for OPS is fairly robust at this point after so many decades of doing this, of organizations having these and then being researched by strong researchers around the world. And really, there's two lines here. One is, what do these sites do for people who use OPS? And the other is, what's the impact on the community? And what the research has shown globally on these government sanctioned sites has been that for the people who use these sites, they help to reduce overdose deaths. They reduce HIV, hepatitis C, and other risk behaviors. They reduce the frequency of drug use. They've been found to improve access to health and social services, including access to medically assisted treatment. In terms of the global evidence regarding the impact on communities, these sites have been found to reduce public injection and improper disposal of needles in the streets around these sites. And also, they've been found to reduce drug-related crime and violence around the sites, as well as reduce the demand for ambulance services for opioid-related overdoses at the sites, mostly because those are being taken care of at the sites themselves. In terms of the United States and the research there, our team has spent the last, I think it's been now 7-8 years or so, conducting evaluation of overdose prevention sites in the United States, and really most of our evidence prior to this comes from evaluating an unsanctioned site, so not a government-sanctioned site in an unknown location in the United States. And what our research has found there was, you know, and again, is really it really helps to show that what has been shown or proven in other parts of the world really seem to be impacted the same way, same kinds of impact in the United States. So with respect to people using OPS, you know, we had a paper in the New England Journal that showed that there were over 10,000 injections at that site, 33 overdoses. All of them were reversed by staff, and in fact, no one needed to. 911 never needed to be called for any of those as well. Our other papers have shown in the Journal of General Internal Medicine that people who went to the site, as opposed to people who did not go to the site in that city, had reduced emergency department visits, as well as reduced days of hospitalization. And then the final paper on that was, we also looked at in JADES, we looked at whether these reduced syringe sharing and drug use in isolation, and they did that, though the p-values were not quite at below 0.05 on those, but nonetheless, certainly we're trending in the right direction. In terms of our work, looking at the impact on the community here in the U.S., then we had a paper that showed that the site reduced the rate of improper disposal of needles in the streets, and then another paper that we published that looked at and found that there was a reduction in drug-related crime in the area around the site as compared to another area of that city. And so both the global impact and also the U.S. impact has been studied quite a bit, and that really leads us today, you know, to the evaluation of what's called the Tenderloin Center here in San Francisco, and this is a site that opened just earlier this year, January 18th, 2022, and it was done under the auspices of a mayoral official declaration that allowed the city to waive bureaucratic hurdles to quickly implement the mayor's Tenderloin Emergency Intervention Plan, which ended up including the Tenderloin Center, or TLC, but also included an impact and effort to increase policing in the neighborhood. So the TLC ended up within a week or so of its opening to include an outdoor overdose prevention site, and that's most of what the evaluation today that I'll be presenting on today is going to show results of. That site did just close 2 weeks ago, December 4th. 2022, the mayor's official declaration was a temporary one, and so I think it was always perhaps going to have an ending date, but nonetheless, this is something that just basically existed for about 11 months, from January 18th to December 4th. The evaluation components for this project was really 4 major efforts in such a short time. The first was to quantify guest use of the TLC as well as overdose data on site, and that data exists. In fact, the guest use data even exists on a dashboard on sf.gov. I'll show you the link to that later on, which is really handy and a nice thing for SFDPH to do. But we also have the data from that. There's also critical incident report data, which includes any critical incidents, including all of the overdose data. And so that's one of the things we've been analyzing as well. And then we embarked upon a pretty intensive project to get a sense about how much time people spend at the site. And given that, you know, these sites are anonymous and they're confidential, you know, we essentially ended up using QR code scans. You know, you might have at some stores, as you've seen, and then wristbands that people, when they came on, they'd get a wristband with a QR code, and then it'd get scanned in. And then when they went to the OPS part of the site, they would also scan in there, so we could see whether they whether they were using that part of the site. And then when they left the overall TLC, they scanned out as well. And so that was a major undertaking, actually, in terms of figuring that out and how to do that. The second evaluation component was a 6-month-long participant observation ethnography, which also included qualitative interviews. We had 1.25 FTE ethnographers working on this project who were essentially spending their whole time in and around the sites, conducting observations about what they could see, writing field notes each day, detailed field notes about what they were seeing and how they were experiencing what was going on. And then there were recorded interviews with TLC staff from each of the organizations that worked at the site, DPH, Health Right 360, Code Tenderloin, and Urban Alchemy, as well as TLC guests and community members around the center. So far, 46 of those interviews have been done, recorded, transcribed, and we have about 4 more that we're going to do before the end of the year at this point. The third component is a systematic observations of the streets around TLC and a comparison neighborhood. I'm going to talk about those methods a bit later on. But essentially, between July and September, during the years of 2018, 2019, and then now here in 2022, we had research assistants who walked around these blocks, both around the TLC and also in a comparison neighborhood to count and look at and observe, you know, various kinds of things that are drug-related and homeless-related things they would see on the blocks, and I'll talk more about that in a bit, but that was also part of it. And then the last piece is a secondary analysis of crime data. This is not completed yet. We're kind of waiting for some of the data to come for that. But around the TLC, some of that is complicated also due to the fact that the Tenderloin Emergency Plan included not just the TLC, but also increased policing as well. And crime data is a form, you know, is a function of not just whether there's a crime there, but also whether there's policing there. And so if you have an increase in policing, which happened here, then you might actually see an uptick in crime as well, as observed by police. So the timing of this evaluation, then, it was planned originally to start in May and then to go through June 2023. We received institutional review board approval on June 30th. The TLC then, as I mentioned earlier, was closed just a couple of weeks ago. And so our evaluation project ended up being much shorter than we had anticipated, 6 months shorter than we anticipated. And it ends at the end of this calendar year in a couple of weeks. And so these are preliminary findings. They're not, you know, completely done yet. But you know, that's partially because this project was cut so short. So in terms of an evaluation timeline, then what you see here is all the months in 2022 on the bottom here, and you see up top then the guest use data of the TLC and the overdose data on site is something that we have all the data from basically the whole year. The same will be true of the secondary analysis of the crime data around there. That's also something we're going to end up having data for the whole year for. The ethnography and the qualitative interviews portion of this could not start till July 1 then, because that's once we had the IRB approval, just a couple of months after getting this contract. And then the same, as I spoke about, the systematic observations of the street was something that we did July through September, in part because that's the same months of the year that this had been done in 2018 and 2019. So you want to have, for seasonality, you want to have the same months. So the Tenderloin Center has really a lot of services, and these evolved over time to include quite a robust thing. It takes a time, it was really the site was put up on just a couple of weeks' notice, and so it really with time and by the end of it really had a comprehensive piece. They had a lot of basic needs that were being met there in terms of food, bathrooms, showers, and laundry. Clinical needs were being met through emergency medical technicians who were on site. Also testing and vaccinations were happening on site, and then wound care and some medical care happened on site as well. Substance use, also a big piece of it, including having, by the end of it, having on-site addiction medicine providers, buprenorphine treatment, people accompanying people to enroll in methadone and residential substance use treatment, and a whole host of other substance use treatment aspects that were on site there as well. Similarly, mental health services were also on site, psychotherapy included, and counseling, and then ongoing relationship with staff that really helped to reduce isolation as well. There were supplies, there were other services that I've listed here. You can see some of these services, and I will certainly mention some of those later on, but reentry, housing, assistance with applications to Medi-Cal, etc., employment services. There was a lot of different things that were going on there. And not only were these happening on site, but they were from the get-go, they were also referrals to these kinds of services around the city as well. And you can see a listing of some of those things right here. But basically, they were all started with referrals, and then most of these services, all these services were provided on site with time, but also some of that would be referred out. So then what we were trying to study here and then talking with people about what the important thing was at the onset of this project was, well, what were the research questions? The research questions started with things like, well, would people even come to one of these sites if you open one of them? Will they use these services? Will they feel comfortable spending time at this site? Those were sort of the first order questions. And then there were concerns about when people are going to overdose on site, and will the people who overdose die on site? That's another big question there that we're going to be showing and sharing data about. And then there are also questions about, will this attract people from other neighborhoods to the area, and will there be an increase in public drug use and improperly discarded drug use equipment in the area? Those were some of the concerns people had at the onset of this study, not the study, but at the onset of the project being implemented. And so those were questions that we were also tackling with the research that we were doing here. And finally, both will there be increase in crime in the area? As I talked about, that's not something we have data on quite fully yet analyzed, but it has some complications associated with it as well. And then finally, in what ways can this model, the TLC model that really evolved through the year, how can it be improved? So then the first order of questions here then, though, starting with, will people come? Will they use the services? Will they feel comfortable here? We draw from the data sources here of the guest data of QR scan, the scan project, and also ethnography. What you'll see here first then from the scan project was that there were 124,000 visits in this 11-month period at the site. And what we learned from the SCAN project was that the median time spent by TLC guests at the site was 1.7 hours per visit. And actually, that was an hour longer median time for those who spent time in the overdose prevention area. So 2.8 hours that they were spending on a median visit at the site among this 124,000 visits. What that really comes out to is just over 18,000 hours a month where people are at the site, which of course means they're not in the streets, not in public areas, but they're actually at the site for about 18,000 hours a month. That's quite a lot of hours off of the streets that people were spending at this site. I'm sharing some data here from that you can also see, and I have the link at the bottom here, at the bottom right of this, from the dashboard that the San Francisco Department of Public Health put up. But just to give you a sense here, what we're talking about in terms of basic necessities being met, and the kinds of reasons why what services were asked for by the people when they came to the site. And you can see basic necessities, space, harm reduction services, housing, medical care, behavioral health, these sorts of things. They served about 100,000 meals during this time period. 9,000 almost showers provided, a lot of laundry, a lot of applications for various services, and Medi-Cal also took place at the site. Other activities you can see here, from behavioral health to housing, 6,800 those, physical health, social services. There really is a robust amount of activities that were happening at these sites. Here you look at the housing assessments, over 2,000 of those done at the center, and referrals as well. And so what our ethnography has found, and what we found through this ethnography and through the qualitative interviews that we conducted, is a few themes that we are currently addressing, and we're currently looking at and evaluating. And I've got a couple of pages here of those themes. The first really is this idea of radical hospitality, which the staff at the site really mentioned that as their overarching frame for how they saw that they do their work, they carry out their work, was this idea of radical hospitality, which is to really welcome guests, to create a safe and hospitable place, a place they want to be. And really what we found was not just were people who we talked to, did they feel they were safe from violence there, but also from overdose. And what we mean by that, which was an interesting piece, is that people were relieved that there's somebody else that's gonna take care of overdoses for them at the site, as opposed to when they're out in the streets or where they're living. They have to do those overdose reversals themselves most of the time. And so this was a nice place to be, where they felt like they didn't have to think about those or worry about their friends or community members overdosing when they were at the site as well. They found, the guests found that the program was designed was conducive to a lot of different community building activities. They had everything from they had karaoke machines there, which helped the community. They had an art room. They had a lot of different things that was just nice for people to get together and be able to talk to each other and enjoy a meal together and those sorts of things. And really, what you looked at here was then also a second theme there, which is really like this whole one-stop shopping aspect here. In that this is basically low threshold entry leads to the opportunities to access a lot of services. Maybe they come for the food to begin with or something like that, but once they're comfortable, they also then would be referred to or would ask about or could receive wound care, therapy, housing, substance use disorder treatment, all kinds of different things in one place, as opposed to having to go out into various different parts of the city. One of the things around the resources there that we also heard quite a bit about was that although most participants highly value having access to this site, they also did describe some long wait times sometimes up front, some supply shortages of different kinds of supplies at times, some staffing shortages, and the need really for all staff to be trained in what they talked about in terms of this whole radical hospitality or even harm reduction way of thinking that needed to happen there. The substance use disorder treatment engagement on-site became an on-site treatment services, which was from what we talked to both staff and guests there, is it really a pragmatic way to first engage people while they're there in these kinds of things. Maybe people are using drugs and they can be talking about them, well, what's going on in their lives, and are they ready for these kinds of things, and would they like to do that? There were methadone clinic staff on site who would invite people to ask questions about what that process will be like or how it will be to be there. And they would even then walk folks over to their methadone treatment who wanted to enroll. There were other engagements in Suboxone and treatment navigation and really having the opportunity for deeper relationships and care navigation with people in terms of what their needs are regarding substance use disorder treatment. The mental health aspect, treatment aspect is also right there. On-site psychotherapy started after a little while, and the need was overwhelming to the sense that they ended up increasing the hours and staff to meet that need. And I'm sure they could have done even more of that at the time. And so that's something to think about for the future as well. And the last theme from the ethnography with this respect is, this is, really needing to find a balance between, there were different organizations providing different kinds of services at the site, many of them in the same space, not all with the same kinds of mission and understanding or training, and that both provided an opportunity to provide a diversity of needed services, but also it meant that teams came from different backgrounds, and some maybe needed more ongoing treatment, training and de-escalation and the kinds of harm reduction and housing and those kinds of things, services there. And so that's an ongoing need, I think, when you're there. Next up was looking at this piece about overdose. Will people overdose there? Will people who overdose die at the site? And so we have the data both from the critical incident report data, which I mentioned, and also the ethnography that we conducted. And what you see here is that during the 11 months, it's 46 weeks that it was open, 333 overdoses happened on site. Nobody died at the Tenderloin Center. That's remarkable, though it is very similar to data we've seen pretty much everywhere else in the world at this point. So it's not surprising, but it's still quite notable. 75% of those overdoses did involve calling 911, mostly because of policies by the Department of Emergency Management as well as the fire department. And that's something I will talk a little bit more about later. But essentially what you see here is a median and a mean around 7 overdoses per week. So that's about one a day. The minimum was one and the maximum was 22 in 1 week. It does vary a bit. It looks like it's a little bit more later in the year. This is a lot of overdoses, and we're not that surprised about that in general. And in terms of where these overdoses were, the majority were in the courtyard, which is where the overdose prevention site is. The area is, but also notable that there were other areas that these overdoses happen as well. Other floor areas, a shower, treatment rooms, and then also 37 folks who were like in the streets nearby, and people came running saying, "Hey, someone's overdosed here. Can you come and help?" And they would come and help there as well. And so it even helped with some of the folks around that area. A back of the envelope, and this is not the most strong or rigorous science per se, but just to give an example here and take a look at what does this really mean, and what could we expect at a site versus what we expect at the rest of San Francisco. The TLC had 333 overdoses. No one died there, so 0% of people died at the site. If you then look at data and some in the rest of San Francisco during these months, there were about 2,500 911 calls that had reversals. The Drug Overdose Prevention Education Project reported over 4,000 reversals. And then there was about 501 overdose deaths, and those data go through October, not through today. But somewhere around 7,000 overdoses then happened in the rest of San Francisco during this time, of which 501 were people who died. And so if you look at it in the community, about 7% of all overdoses end up in death. Whereas at the site, no one ends up dying at the site. And so this is quite a stark difference if you look at this. In terms of the ethnography results, and we did quite a few interviews and talked a lot about overdose here, as part of that, and a lot of interviews there. There were 3 EMTs that were on site at different times. and they were really, committed to improve the overdose responses, and they felt empowered to define and to help really refine the on-site overdose protocol in many different ways throughout the time. That meant that they, together with EMTs, together with health workers, as well as guests who also helped quite collaboratively as well many times, they were saving multiple lives every day, as we looked at, as the data showed there. That work is emotionally draining, but it also really, imbued a sense of meaning to the work among all the people who were working at the site. And I think that's an important piece of doing this work is, people really were invested in doing this work, and in part because they realized how impactful it was. The addition of oxygen for managing overdoses was expanded after a couple of months, and it really expanded the toolkit, what they were able to do. This provided a much more sort of nuanced protocol to meet the needs of the guests experiencing overdoses, and it really reduced the stress among the staff. The staff there are much calmer about overdoses happening when they also had oxygen on site to help manage overdoses as they were happening. So that's a big thing to think about for the future as well. And really, with this more robust protocol, having to call 911 for all overdoses really became redundant, even though the protocol is to do so. That's a question whether you really need that for each and every one of these overdoses when they are being managed quite effectively on site. So the next area of questions come here about, will TLC bring people from other neighborhoods to the area? Will there be an increase in public drug use and improperly discarded drug use equipment in the area? So these data sources are the guest data, and then also the systematic observation data that I spoke about earlier. In terms of the guest data, there was a couple of month period there in the spring where all guests were actually asked, when they came in, what neighborhood they were coming from. About 94% came from the Tenderloin, which is the immediate area, obviously there. And another 1.7 came from South of Market, which is really the adjacent area as well. It's basically the vast, almost everybody came from a very, very close place. We're talking about a few blocks from where the TLC is. The systematic observations of the streets. So what this is what we essentially did was create a 500-meter radius around the TLC, which is where the OPS was. And then we also created a 500-meter radius around the Mission Neighborhood Resource Center in the Mission, which is a similar type of place, which also, it's a resource center for people. It's a drop-in center. They have a medical clinic there as well, but they don't have overdose prevention site there. And so that's the comparison. And then we had two of the research assistants, Terry and Vero, walked each side of all the blocks in that 500-meter radius. They recorded on tablets all drug and homelessness related activities and artifacts and those sorts of things. And again, data was collected in 2018, 2019, 2022. Did not have data in 2020 and 2021 because those were the COVID years. And essentially, I'll show you on the map there and talk a little bit about that. But the systematic observations then that they collected data on was each time they walked in a block, it was a set of drug-related issues. Are people smoking drugs, injecting drugs? Can you see people selling drugs? Are there needle caps, syringes, those sorts of things? And then homeless related issues as well in terms of is there visible human excrement? Are people sleeping? Is there tenting going on? Are there shopping trolleys? Other kinds of things on the blocks as well. And so what you see here is a slice of map of San Francisco, and the green big circle here is the 500-meter radius around the red dot, which is where the TLC is. The comparison in Mission Neighborhood Resource Center here is the purple dot at the bottom with a multicolored circle around it, essentially. Now we had anticipated because back in 2018 and 2019 there was talk about an OPS opening or a safe consumption site opening at that time, and so we actually, before they opened at that time, we did data collection at four different circles that happened to be in the Tenderloin and South of Market area, because that's what we expected, or we thought at the time is where these kinds of sites would be implemented. And so we have data from 2018 and 2019 that weren't part of this project, but we're in anticipation of something like this happening. And so then what we did was we took, all the data we had in 2018, 19, and 22 for all the data points you had, all for all three of those time points. We used that as the basic observation data, and then a comparison in the Mission Neighborhood Resource Center, which we had for all three of those years. What we found then was that in 2018, and what you see here is the red is the area around the TLC, the blue is the area around the Mission District, and the red, basically what you see is that the probability of there being any of these issues, drug related or homeless related, on any block was about 50%. That went up quite a bit. In 2019, things were increasing, and then you get all the way over to 2022, just about 6-7 months after the opening of TLC, and actually these numbers went back down to 2018 levels. We have the same data here, just specifically for the drug-related issues, removing the homelessness things, and you basically see the same thing. You see an increase between 2018 and 2019, and then a drop, a statistically significant drop to 2022. There's certainly lots of limitations. They only went to these blocks one time. They didn't go every day. That didn't have resources for that, and that's not the data we had prior either. So we wouldn't have been able to do that. But nonetheless, it is a window into this particular issue. So then the summary of findings to date, then, what is it that we found today? Well, first of all, 333 overdoses happened at this site. Nobody died. That's number one, and the most important, really. And then on average, guests spent about almost 19,000 hours at the TLC every month. Which is time they were not on the street, and it was time that they were in a place where they felt safe and they felt comfortable with how things were, and there was lots of different resources and services for people to access. The TLC model was appealing to guests. Everybody liked them. They certainly had recommendations for things they would improve, and some things along the way, and many things did improve over the time. They had problems or concerns, and those were changed. As this was a dynamic, really changing model as the year happened. And so really what we find here is that if located close to areas of drug use with really low threshold access and trained staff, people will use OPS in San Francisco, which was a main question really at the beginning. And co-location of OPS with health, substance use, and social services helps to reduce barriers and connects people to life-saving support. There clearly is a sizable need for overdose prevention sites in San Francisco. These sites, we need ongoing support, daily briefings and trainings that would continue to help improve staff wellness and their ability to conduct this very difficult work. And the amount of drug use, public drug use, and improperly discarded equipment in the area was really the same post-implementation as it was in 2018, and it was actually lower, 19% lower than in 2019. So the main recommendations then, the preliminary recommendations we have, with 2 slides of recommendations here. First of all, open more overdose prevention sites, and with more open hours in San Francisco. I don't think I mentioned, but it's open. It was open 8 to 8, 7 days a week, opening a little bit late on Thursdays. I think it was 11 open on Thursdays. But later evening hours was something especially that women talked about wanting. And so that's a first recommendation. Co-locating OPS with basic needs resources, health, substance use, and social services. That's also something we recommend that for that to happen as well. Increase staffing and capacity to reduce time for guests in waiting lines, so people aren't standing in waiting line. If you have a few of these things, I think you would take care of that particular issue, but you can't just have one site in San Francisco. There's lots of areas that need to have these kinds of sites. Provide ongoing de-escalation training for employees and support and management for employees who are working these sites. Implement same-day debriefs for staff about overdoses and other incidents where they can talk about and share experiences and learn from each of these things, and just kind of debrief from them is another recommendation. Improve inventory, ordering of harm reduction supplies and oxygen. I think there were some supplies issues, and I know there's been supply issues with lots of things in the U.S. over the last a year or so. But it was also, it became an issue here that needs to be that's something that could be improved. Host listening sessions with guests for their feedback, so you can get direct feedback rather than having researchers. We certainly do that, but it's not as efficient, certainly, to have a research team come in and do those kind of listen to these things and then feed that back to sites as it would be if basically they were holding their own listening sessions with guests and hearing about feedback. Change the overdose protocol such that 911 is not required to be called for every overdose. This was a big one, and I can say lots of EMTs that came to the site were wondering what were they even doing there, given that the person had already been, their overdose had already been reversed. There's really no need for them to be there, and it's a waste of the city resources to do so. You certainly, sometimes that's called for, but you can make a protocol related to that. And certainly the New York site, for example, I think less than 25% of their overdoses they actually call a 911 for, and so that's definitely shows that's possible to do in a different way than what's been happening. And the last recommendation is to create opportunities for guests to participate as volunteers or paid workers. The guests who went there, they really they wanted to do more. They wanted to give back. They wanted to be part of it. They wanted to see how they could help as well. And so I think that's a great opportunity to have some sort of a program where you can do some employment development there and also help having them be part of it. So the next steps for this project, which is ending in a couple of weeks, is we are submitting manuscripts to medical peer-reviewed journals on these evaluations results. We're continuing to do an analysis of the qualitative interviews and ethnographic data, focusing on the impact of the TLC on guests, staff, and the community to inform future program implementation. We've got, I think, about another 4 qualitative interviews we'll be doing as well as part of that. And then complete the analysis of the crime data. I want to, of course, acknowledge many people who are involved in this. First of all, this work was conducted with funding from the San Francisco Department of Public Health. There's also we have the deepest gratitude to all the people we interviewed. Each of them provided us with great insights and expertise, and so many people. And also thanks to the organizations at the TLC, Health by 360, Code Tenderloin, Urban Alchemy, all of who really welcomed us there and helped provide entree to us to conduct our research and be able to do all the work that we were able to do there. With that, I think that's the end of the presentation, and certainly if you have questions, this is the time for that, but also here's my email address in case you want to send me questions at some point over email. You can do that as well.
Wow, that was fantastic. Thank you so much, Alex. That was a lot of data, and a lot of people have very, very good questions about certain parts of the project. So one question relates more to the beginning of the presentation when you were going through all of the available evidence that across the globe, all of the benefits, both from individuals and communities, from overdose prevention sites. And the question is, what research or evidence, if any, is needed still to expand OPS access? Like, why hasn't it been more readily adopted in the United States? What evidence is still missing, if any? And are there any populations that are frequently excluded from this research?
Yeah, I mean, there is a robust existing data. In the U.S., from a policy perspective, there always seems to be this sort of U.S. exceptionalism piece. whereby, well, that's data from Canada, that's data from, Europe. It doesn't really apply to us in the US in some sort of way. And you hear that a lot of times I think in health policy in general, but specifically in drug policy. And so I do think, and we hear a lot about, and the federal government, certainly in conversations, the National Institute of Drug Abuse director, Nora Volkow, for example, she has said she is in favor of these things, but she's also asked, where's the data from the US on this? And so I know they're, getting set to do some evaluation or fund some evaluations, hopefully in the US there as well, to be able to create that data. But I don't think the policymakers in many places are comfortable with just data across the globe, and certainly they've been comfortable enough with some of this data that we provided on the unsanctioned site. But again, an unsanctioned site is different than a government sanctioned site in many different ways, and actually much more limited in the kinds of things they were able to do. They couldn't have medical staff on there. They couldn't have, they had to be basically underground, and so it limited what they were able to do. But even under those circumstances, there were a lot of positive things that basically showed very similar things as what the global data found as well. So I think the short answer is, you would hope that the data from around the globe would be sufficient to pilot and start these kinds of programs in the US. A couple have now started, but I think that there's more data needed still in the US, unfortunately, to convince some local places for that.
Yeah, totally. And to answer the second part of the question, do you feel like there's any populations that are missed or excluded in the research that is available?
I mean, these tend to be mostly, because there's so much stigma around drug use in the United States. The only people who tend to go to these sites are people who are at the point in their life where they basically feel like they kind of have nothing to lose in terms of outing themselves as being people who use drugs, going to these sites. And so that is that your middle class folks who use drugs are not often going to these kinds of places. I think if you have lots more of them, and that they cater to different kinds of populations in different kinds of ways, and I think that there would be other kinds of populations that might consider coming, especially for some of the ancillary services that happen there as well.
Yeah, that makes a lot of sense. So the idea of tailoring OPS to the site in which it's providing in the surrounding communities. Mm-hmm. As the next question, it seems like, the preliminary data seems to suggest that there were a lot of benefits from the Tenderloin Center. Given that was the case, to address sort of the elephant in the room, why did the city choose to close the TLC permanently earlier this month?
Yeah, that's really a question for the mayor, I think, in the mayor's office. I don't really have the answers for that question. As I mentioned, I think it was conceived of as a temporary effort as part of a declaration of emergency for the Tenderloin. And as such, it wasn't a permanent thing at that point. I do know, I think the Board of Supervisors met just a few days ago. They have a majority of the Board of Supervisors, I believe, that are interested in making sure that these sites are opening up again. The San Francisco Department of Public Health has an overdose prevention plan, and for this plan, that includes something called wellness hubs, which do include overdose, which could include overdose prevention services as well as part of them. And they've said they would open some of those sites, but the when and the wheres, I think, is the question at this point. And it seems like the Board of Supervisors is trying to have some urgency about making sure that happens sooner than later. But I don't really have an answer as to why it did close per se.
Yeah. Thank you. One question says, thanks for this excellent presentation and for doing this important work. Two questions was data collected on which drugs people were using? And then the second question was smoking allowed on site?
Good questions. We did not collect data on which types of drugs, not quantitative. We certainly did as part of our ethnography and our qualitative work. And smoking was allowed, and in fact, the majority of people were smoking rather than injecting on site, and so there was an area for injection, and that area, when you were there, usually would have somewhere between 2 and 6 people in it or something like that. And then the other area where smoking was allowed, would have like 40 people or something like that. And so it was really, and that really reflects what's happened in terms of the drug supply and how people in San Francisco are using drugs at this point. And it's, most people are smoking fentanyl as opposed to injecting fentanyl. And that's something that we've published data on in San Francisco showing that's a change that happened sometime around 2019, 2020. As well, but it allowed both smoke, and you could really use it any which way you wanted to, but smoking was the predominant, but also some injecting.
Excellent. The next question asks, since you mentioned originally the project had been planned for the 12 months, but it was cut short to 6 months because of the center closing. Since the timeline, you're given another 6 months until June 2023, you have IRB approval. Is there ability to continue following up with guests who use the site after the closure to see, what's going to happen with people, to see the long-term impacts from prior engagement? What other things, if any, do you plan to do in the next 6 months?
Yeah, so the contract was cut at December 31st, and so the funding for this project is over in 2 weeks, and so we no longer, as originally we were going to have funding through another 6 months, and we would have been able to use that. You're right, we do have IRB approval to continue on that, but we don't have any funding. We would need some funding to continue that work. Certainly since December 4th, when it was closed, our ethnographers are on site. They are around there. They are talking. They are having these kinds of conversations, and they've added some qualitative interviews as well during these last few weeks to get a sense about really what happened immediately afterwards. I'm looking at questions like, where are you now getting services? Where are you staying? How are you using drugs? What are you doing when you see someone overdose? How are you taking care of those things? How would you go about entering drug treatment now? Do you know how to do that? Do you know where you would do that? Those sorts of questions we're trying to ask now.
Yeah, so important, especially since we have this time frame in the immediate short term of what happens after the closure. The next question is, what strategies have you explored with regarding dissemination of your findings to the San Francisco community?
Yeah, that's a good question. We're going to be exploring more of those. This data has just come about. As I said, these are preliminary findings. We've presented, and we've been wanting to present certainly to the Tenderloins Center staff as well. But we're hoping to finish off some of these things, and we're happy to present this in other venues as well.
That's awesome. Another question is phenomenal presentation, Alex. We are so lucky to have you to do this work. How did COVID-19 infection and control practices affect wait times or access, if any? And any reflections on this from guests related to COVID-19 infection control?
Yeah, I think ultimately COVID didn't really impact much, mostly because the overdose prevention site was outdoors, and so that really reduced the risk for transmission. And the one thing is that the waiting area to get in was outdoors as well, which is good for particularly COVID reasons, but also wasn't great necessarily for the community members to see a line there, or for people who were being in line. The fact that they were being seen doing that was not something they liked as well. They did shift that in the last, I think, month or two or so into having kind of a more hidden line outdoors that they had. They kind of created a different fencing mechanism to do that. And then people were required to have masks if they were inside, which was at all times. And then, as I think I mentioned up front, there was, there was testing, there was vaccinations, those kinds of things were happening there as well.
Awesome. The next question relates to other harm reduction services. So one person would like to know, were there drug checking services available on site? And then also, did we administer both naloxone and oxygen to reverse overdoses? Did we use one more than the other?
Yeah, there were fentanyl test strips available for people to test their own to test whether there was fentanyl in their own sites. I think, were there benzodiazepine test strips too?
I don't think so.
I don't think so. But there was not an FTIR machine, which is something that's been starting to be implemented in certain places around the U.S., including San Francisco. The San Francisco AIDS Foundation, through their syringe service programs, have an FTIR machine, which we're evaluating that as well. But there was not one on site during this year, and I think that with future sites, if there are future sites, that would be another recommendation we should really have added to that list, is to include drug checking machines also to those sites. I think that's another piece to say. The data on oxygen versus naloxone, the first 3 months, actually the first 5 months, there wasn't oxygen there. Once oxygen happened, it really sort of depended a bit. There was a mix of whether you use oxygen and using naloxone. I don't have the data right in front of me. Leslie, do you recall? Is it about 80%? Narcan was about 75%, I think.
I don't recall, but I think oxygen was used more than the naloxone.
Yeah, towards the end, and some people you would maybe start with oxygen, and if that wasn't enough, they would use Narcan. But by the end, I think there was a lot more oxygen being used than there was naloxone. But over sort of the whole year, I think there was more naloxone used than oxygen.
Yeah, great. And then the next question relates to sort of who was allowed to use the center. So were youth who were younger than 18 years old, were they able to use the TLC? And did you encounter any unique barriers to providing services to minors?
I don't have a great answer to that. I think youth under 18 were not supposed to be there, but I don't think there was ID checked because of confidentiality reasons. That's my sense. That's my sense of it.
Yeah, that was my sense too. The next one is related to methadone access. So how far away were the methadone clinics from the Tenderloin Center? And maybe I can weigh in on this too, Alex.
Please do. Please do.
So there are two methadone clinics very close to the Tenderloin Center within 2 blocks. One is and they both belong to the BART methadone treatment clinics. So one is BART Turk and one is BART Market. And so those are the main referral methadone clinics that people would walk, and they were literally within walking distance.
Just a few blocks, like 3-4 blocks, really.
Yeah, exactly. And then the next question is one person says, thank you for this interesting presentation. Were the QR code scans also used to track uptake of services and time spent with various service providers in the Tenderloin Center?
Yeah. That's a good question. We wanted to do that, but to be honest, the QR code machines were they were temperamental, I will say. And so we didn't use those for the entire project. And the idea up front had been to do that. So when any service that happened, you would essentially show your wristband to, but that ended up not being able to happen. I think maybe in the future for another project, perhaps if you set it up, you have more time to set it up, and you could potentially do that. But we ended up not doing that. It's a good idea, and we tried to make a go at it, and it didn't quite work.
Great. Another person asks, how did guests learn about the Tenderloin Center? So much of using the center depends on word of mouth or advertising. And so how did people find out about it? And is there opportunities to even spread the word further?
Yeah, I think there was outreach services that were included in this and going out to that, and there were groups, certainly Code Tenderloin and Urban Alchemy, who were the ones also working on site, that as well as Health by 360, all of them had outreach workers and people who were in the neighborhoods. The idea around the center was for it to serve around that neighborhood and not sort of the whole city, and so the area that they needed to outreach to was not that large, and so I think it was pretty easy to be able to do that. I'm gonna guess that most of the people in the close by neighborhoods probably knew about the site, but certainly by the middle of the year.
Yeah. Well, so I think we're out of time today. Thank you so much again, Alex, for this incredible presentation. So many questions were answered, asked, and elucidated. So really, really wonderful to see. And thank you everybody for attending. We wish you a happy holiday season and peace for everybody. Take care.
Thank you everybody for allowing me to present. It was great to be here today.
Thanks.
Take care.